Well, first, I want to thank everyone for making the effort to get together at 4:30. You know, just before coffee time. It's sacrifice, especially for me. And I do want to introduce Jessica Martin. She works with us on a lot of our patients that we're going to discuss today. Why would we put on
Is Dr. Ironheart?
No.
that would just concentrate on this specific entity, which is a language deficit? And the reason is that oftentimes we have lots of patients in this predicament, and it's very hard to there's a lot of landmines in hearing for them, understanding what their world is like. And so I wanted to take them out of just the general larger categories and just focus on this language deficit. Our goals for today are, one, hopefully that the patients themselves will be able to listen to what the problems are and have confidence in themselves and help them perform better. The second thing is for the caregivers to get more skillful in understanding the world that these patients live in. And then also for us, in any time that you have to give a talk or you have to convince people or something, you have to get better at it. So I'm hoping that this will help us get better at taking care of our patients. First thing I want to do is to tell you a story. Okay, this is a composite. This is a composite of several stories, but it kind of brings out all the issues that we're going to deal with. A woman, she's 60 years old, has a stroke. It affected her left brain and her right body. The speech center in 95% of people is on the left-hand side. So initially, she is unable to speak, and she has weakness in her right hand and her right leg. She goes to the emergency room, they make the diagnosis of a stroke, and then they give her a thrombolytic, which breaks up the clot in the brain and brings her back to the room. Her husband's waiting on her. In the first few hours after the stroke, she immediately starts to get the strength back in her hand and in her leg. And over the next 24 to 36 hours, she starts to speak again. That speech is impulsive. It's got nouns, and it's got verbs, but it doesn't have any conjunctives, doesn't have any adverbs. It is eat, window, coat, beeper. It's one word, or eat. And then over time, over the next couple of weeks, the speech starts to improve. There is speech therapists that are involved, and the patient is doing physical therapy, and we are reaching we're getting better. Now, this couple is a power couple, okay? The wife, the patient, is a lawyer who works here in Charlotte, and she's an elder lawyer. She's a civic leader, and she makes her living with her work. And she is in with her clients, and she's in with her other board members and things like that. Her world is her words. The husband works for the bank. He is a hotshot. You know, in Charlotte, North Carolina, in New York City, they say that the only time that people are really respected is people that have a whole lot of money. All right. In Boston, you got to be really smart. Okay? In Philadelphia, it's all about your family and about who your father was and grandfather was. In Charlotte, you got to be a banker. I mean, who would have, thought that? But he's a banker and he's a problem solver. When something happens at the bank, they fly him in to solve the problem. Okay. Also, He is a verbal soul. He makes his living in sizing things up, solving the problem, and then explaining to the rest of the world how he has done it with the words that he has in his brain. So we've got two incredibly verbal people who are now in this predicament. The husband has the idea that I'm a problem solver, and I'm not so sure anyone as smart as I am has ever confronted this. So I'm going to find a way to fix this. I am going to get the best speech pathologist. I am going to do everything I can to bring my wife back to being normal. She is at first very empowered by the fact that she has gotten better. Over the past 4 weeks, she has worked so hard to come back, and now her sentences are starting to flow a little bit. Now there's a few adjectives there. There might be a conjunction, but we're getting better. The husband, every evening, he has certain words and certain things that he reads to her and makes her read back to him. And he is going to laser focus this because we are going to beat this. What happens is that we get to about 6 weeks out and we reach a steady state. Okay. We're not improving quite as much as we were, maybe not at all. And all of a sudden, there's a little bit of a realism. The patient starts to lose a little bit of confidence. They're trapped in this silent world. And they're trying hard to live up to all of the expectations that the world has for them. I know what I want to say. You don't understand. It's right here. Now just be patient. Just be patient. It's here. But it doesn't come. And she starts to cycle down a little bit, starts to lose confidence, starts to get very anxious, and becomes extremely quiet. The husband, all this does is ramp him up. Okay, we are not going to be defeated by this. We are going to win this, and I am going to show you how you do it. So here we are. We've got this clash. They come into the office, and I meet with the husband, and the husband says, I think she has dementia. And I don't think she's understanding what I'm saying to her. I really don't. And I think that I'm losing her because she's moving away from me. You've got to help me with this. I go in and talk to the patient, and at first we just sit there and kind of smile. No pressure, no anxiety. And she says, I feel like I'm letting myself down. And I feel like I'm disappointing my husband, and I feel like I'm going to lose him if I don't get better. So I've got two sides of two people trying their very best to deal with this tragic situation. The husband is saying, I love you, and I am going to do everything I can to bring you back to normal. The wife, the patient, says, I'm doing everything I can to get better. I'm sacrificing everything, and yet I don't feel it's enough. So what I have to do is kind of bring them into the same room, and we have to have a talk. We have to understand about the expectations of where we are. If the expectation is that this is going to go away and that we're going to get beyond it, totally unreal expectation. If the expectation is that we can live with this and work with it, then we can make it, okay? So I want to set up this scenario where you see both sides of these people acting on their best. But what's happened is they're asking the wrong questions, and they're going, if you are a problem solver, okay, and we see this all the time dealing with not only expressive aphasia and language issues, but in dementia especially, is if you're a problem solver, you're going to do everything you can to solve that problem. You are going to hit your head against it. No one else has ever done this, and you're going to be bloody. And then what you do is you create a problem around it that you can solve, okay? So that's where we are right now, okay? And so we're going to kind of, I'm going to turn this over to Jessica. We're going to talk a little bit about what she is thinking when we call her to come and deal with the patient, okay? Thank you, Jess.
Okay, so one thing that he mentioned is, of course, with stroke, we're going to see aphasia, but we may also see it with dementia. So first thing I'm going to do when I go into a room to see somebody is try to figure out which one we're going to be working with. Because with stroke, we're going to be able to work and compensate and teach different strategies. With dementia, it may be more that we're going to work with the caregiver on teaching strategies. So it depends. So first of all, I just kind of have to figure out which one we're going to be working with, especially with cognitive impairment related to dementia. If it's early stages, not sure if y'all are familiar with the global deterioration scale, but if it's a 3 or a 4, we're going to be working a lot with the patient. I'm trying to teach some strategies. If it's later on, that's when we're going to be working with the caregiver. So a lot of the speech therapy is going to be kind of figuring out how we're going to approach it. I'm going to go in and I'm going to look to see, is this person able to read and comprehend what they're reading? So let's say I write down some instructions and I say, point to the door. And I said, I want you to follow what's on this piece of paper. So this gives us a strategy. Are we going to be able to use this to communicate? So if they're able to point to the door, then I understand, yes, they can read and understand what they're reading, not just reading the word. I'm going to look to see how they identify objects. So is the person able to see this is a pad of paper? And what do I do with it? Are they able to give the word? If not, if I give a field of 2 words, if I say paper, if I say pen, and see which one they're able to identify. So it's a lot of kind of, when we first get to know each other, trying to figure out what strategies are going to be working well. I want to see how somebody does with answering yes and no questions. So I may say, is my shirt green? So I'm looking to see, can you see the shirt? Can you understand the color? Can you say yes or no? To see, is this more of a cognitive impairment or is it a language impairment? So there's a lot of different questions I'm going to be asking when trying to figure out how we're going to start helping with the problem. How are we going to work with each person, the caregiver and the loved one, to figure out how we can work together to bring it, to bring the language either back or compensate for it. Also, I may ask them abstract yes and no questions. I might say, does vinegar taste sweet? And so you really have to think about what, okay, yeah, no, it doesn't taste sweet. And so I'm just trying to look to see how the brain is processing some of those type of questions. And then we kind of go from there and make a plan on how we're going to work on the therapy.
All right.
I'm not sure I understand.
Not like that.
That was perfect. That was really perfect.
I want to talk a little bit about when I walk in the room, what I'm interested in when I first evaluate someone that has aphasia. The first thing that I have to realize is that this person has been profoundly affected by this. Okay, we live in a verbal world. We push almost all communications through the spoken word. And when you are living in a world where you are not confident, everything starts to be affected. Now, think about this. When you, and I talk a lot about this with my patients, especially with depression, is that there is an inner dialogue that you speak to yourself. Okay, you are talking to yourself. That left brain, someone says, would you like to go play golf? And are you any good at golf? And your left brain goes, yeah, I'd like to play golf. And yeah, I'm pretty good. And then your right brain says, you haven't played golf in 2 years and you're going to make an idiot of yourself. Okay? So there is a conversation with yourself. That conversation uses words. So even when we are talking to ourselves, words are crucial. And if we can't come up with those words, it affects our business, our ability to be able to view the world and also communicate with other people in that world. So think about that. Okay, so my nice lady that is the lawyer, think about this, that now she's sitting there in her office, and she has to reevaluate her world. She has to say, there are certain things that I can do and certain things I can't do. What do I want to do? How do I remake this world? Because what Jessica was talking about is that her original evaluation was that she's trying to decide whether or not the only deficit is the speech coming out, or does it involve you understanding the speech that's being spoken? Now, the second one gets everybody in trouble. The first one is a little bit easier to deal with, okay? So she has to decide, am I willing to risk to go back on a board or back to my office to take care of my elder law practice with this deficit? How do we do that? We're going to talk a little bit about that, right? I know when I evaluate her that she's going to appear more impaired than she really is. When I evaluate her, when I talk to her, she's going to appear as if she can't communicate. So therefore, people are going to think, oh, well, wait a minute, there's something very wrong here. She's not right. When I test her, the tests are verbally tested. They're verbally scored, excuse me. And so she's going to test much lower. And my whole evaluation is, does she understand what's going on in real time? What's going on now? I don't care whether she can remember it. But when you test low, the first thing that a lot of people are going to do is say, she has dementia. She doesn't know what's going on. And yet she doesn't have dementia. Only 8% of patients that have a stroke that would affect a large portion of the brain will get dementia. But they will be diagnosed with dementia because of their inability to verbally connect. I always know that depression is a huge component of expressive aphasia. If you can only think about, you know exactly what you want to say, and something is coming out and there's a discussion and you are trying to have your point and it doesn't come. So what happens is that you contract, you recede, and that's where the depression comes in. There's also another factor. I don't know whether it has to do with the internal dialogue, but there's an apathy that comes along. If I can't impact life, if I can't punch out and make my point, what's the point? Why do I care? So apathy comes in. And then what's called anhedonia. Anhedonia is the loss of the pleasure of things that used to give you great pleasure. And so we have this cascade of associated entities along with the expressive aphasia. Yeah, I want you to.
So a lot of the treatment that we're going to work on is addressing these. We want to work on getting the words out. We want to work on giving the time, allowing the ability to kind of process what was being said. So if it is more of a receptive aphasia where they're having a hard time understanding, we want to focus on that and make sure that we're allowing them the time to process what's being said. There's so many new technologies that we're able to use. I've got all kinds of apps on the iPad that we can sit down and do activities, brain activities to help with word stimulation, to help with getting the words out. We actually are getting a new device here in our gym that's called It's Never Too Late. And it's a whole device computer system that is used for different ways to stimulate the brain, whether it be reminiscing, whether it be physical challenging things, whether it be cognitive activities. So there's so many things out there that we're able to do that is able to help with language and able to help with speech in order to be able to express what you're wanting to say. So we've come a long way, and it's really wonderful to be able to see the changes that people are having by addressing some of these and really training caregivers and loved ones on how to approach somebody with aphasia.
All right, let me ask you a question.
Okay.
When that internal dialogue, do you think that internal dialogue is affected by expressive aphasia?
Of course. So if you're not able to verbally say something and you're trying to think of it as well, you're also kind of in your brain racking, what am I trying to say? I know I want to tell myself, get up today, let's get going, let's do our routine, let's do everything we need to do to make our day an accomplishment. But if you can't get the words out, there may not even be able to be in there to be able to tell yourself what to do. So really having a caregiver and a loved one really supporting you through this is very important.
That's extremely important. Okay. It does not mean that you do not know how to sequence or that you do not know what you're about or what you want to do. It just means that those words are not lining up. Okay. All right. All right. Back to me. I wanna. So this couple that I have, we are at this standstill. That both feel like that they're losing the other one because of the present situation, because of the fact that we are not improving like we were. So I've had the conversation to try to point out that the husband is saying, I love you and I want to help. But that's not quite enough, because problem solvers are not going to stop. Okay, they are going to keep coming to try to make sure that you understand what they are trying to get across to you. Okay. Now, when the husband spoke to me, he said that sometimes I feel like that she's moving away. She's moving away. And I feel like she doesn't understand what I'm saying. What's happened is that at some point when you are calm and you're not agitated, you can work through an assault or a time when you feel tension. But when you have expressive aphasia and you're trying to work with anxiety, trying to remember and trying to defend yourself, you give up and you have to get away. So it's really important never to have anxiety and pressure in that discussion. Okay, very important. The role of the caregiver is a protector and a facilitator. That we will do much better with the patient in smaller groups. 6 or 8 is a disaster. Okay, 6 or 8 is a disaster. 4 or 2 to arrange 2 people. Oftentimes, my patients that have expressive aphasia, what they'll say is, if I'm with just one other person, I'm fine. Okay, you can hear it all the time. I look up there on that top line and I see some people, and I've heard it 50 times. 2 of us, I do really well. All right, so we are in an art gallery and we're looking at a famous painting. And the husband and the wife are standing next to each other looking at this painting. And they're both taking it in and they both see it. Now, the caregiver or the patient has had the same look at the painting and comes away with their own impressions. Okay. Oftentimes, the caregiver will want to discuss it, but what's the one thing she can't do? She can't discuss it. So why do we make her discuss it? Why not just have this very nice, nonverbal, silent moment where we're sharing something and we don't have to necessarily spoil it with having to beat it to death? Okay, that's what my wife would say. Why do you want to beat this to death? Okay. So if she can't always say exactly what she wants, but she's got that in her brain, she has fully appreciated that the colors and the structure of the painting, let it go. Okay. Now, if you had a situation where you were both completely normal and had the verbal skills, yes, it's fine. But remember what your challenges are. If something, you ready? Yeah. Okay. All right. All right. So foster nonverbal strategies. Okay. On a schedule, on a calendar. It's just out there. We don't need to say, all you do is you have it written, and the patient is equally able to understand what's going on that calendar because they can still read. Now, two is lots of nonverbal signs that are just very quick. Okay, let's say you're riding in the car, and the patient that has the verbal challenges is driving, and you make the point very surreptitiously that we're going to turn up here in 2 blocks, and they just go, I got it. Okay, you don't have to say. Now you need to get in the right lane here because I get to see this. Yeah, I know. And also you don't have to yell. Okay, you don't have to yell because they ears are perfectly normal. All right. The other thing is I want to talk a little bit about the 5 senses. I like to have a sign when the patient feels like this is not a good time for you to want to discuss something. Okay. Now that sign, probably not the best thing to go like that. That's not the sign I'm after. The sign I'm after is just something like, give me a minute. All right, give me a minute. All right, but how do we do this? We use the 5 senses. Okay, we use the sense of touch. The person that has the deficit, they have certain things that they need. They need to know that their husband or wife is in this for the long run. They feel like that, gosh, I've got this deficit now and I could lose my whole life. And how you reassure them is nothing more than you're walking across a parking lot and you grab their hand and hold it. Lots of hugs. What you're saying with the touch and the awareness, especially smiles, that we forget. You're thinking about, okay, now, is she going to understand this? And there's a little bit of a sternness. And if you have a smile, it's like, yes, I think I can communicate better. It's not like that it's a death sentence, okay? Just a smile tells the world, you don't have the best of me yet, okay? All right, the sign about pressure. All right, and then really communicate more with your eyes than you do with your mouth. And if you're saying things, but your eyes say something different, it's going to make them cycle down because they don't trust you anymore. They will say that I read in your eyes that you were impatient with me and that you were tired of this. And yet you said, oh, it's going to be okay. It's not good enough. The eyes will always betray you. All right. Talking is not one of the 5 senses. Okay. So remember that. Okay. Taste, touch, sharing moments that don't have to be verbalized. You sit down for dinner, and at first, we're not going to have the pressure of having to talk. We're just going to sit for a second. Then when the patient relaxes, the anxiety goes down, and they will initiate the conversation. Okay. All right. The one thing that I want to end with here is that I don't want this beautiful relationship that this couple that I've described has to let the one thing that doesn't work to undermine it and to take it away. We've got to find a way not to live without it or that we're going to get better, because that's an unreal expectation. We can get better. We're going to have to live with it in a certain way. So the reasonable expectation is that we can improve and we can understand how we live with this in our lives. Okay. Key word is live with it. Okay. All right, we've got a bunch of questions here. Jessica, I'm going to get you to read these questions, and then you and I will sort of go down. And if there's any, Melanie, are you good to go on the
Yeah,
chat?
I'm
there?
watching. We have a lot of questions that were submitted with folks' registrations. And that's what we'll start from. If you have more questions or if the conversation prompts a new question, feel free to type it in the chat box and we will see it. Or you can turn your microphone on and speak up. Thanks.
Yeah, read the first part. That's a good one for you.
So I've had 2 strokes and would like to know if there's any hope in improving my ability to express myself verbally, to read, and to improve my memory. So from just my expertise is the first 6 months is the most important after a stroke to regain most of what you're going to be able to regain. Not saying you can't do it afterwards. It's just so important right at the beginning. Improving the ability to express yourself. Yes, we can teach strategies. We can work on compensatory strategies. We can work with the family. So definitely there's room for improvement, but each person is individual. So do you have anything?
Read number 2.
Does the person's own frustration of aphasia increase the severity of aphasia? Does trouble finding the words often deteriorate into unintelligible speech? How are aphasia and dementia related? There's a lot of questions on this one. Does dementia cause aphasia, or are there separate symptoms of the deterioration of the language center?
Yeah, that is quite I don't know. I think I know where that question came from. The first thing is what that question is, does anxiety make this worse? There's no one that has expressive aphasia that won't tell you that anxiety is absolutely the death knell for trying to remember anything. It's actually the death knell for all of us. If we lose a little bit of confidence, you remember there was a time when you might have said something and you're embarrassed, and the next thing, and then that anxiety hits you and you can't remember, or you can't start to, even if you've never had a stroke or had any type of dementia. So anxiety over memory loss causes memory loss. All right. The anxiety undermines your memory. As far as dementia, vascular dementia, oftentimes language is spared. It's one of the things that we immediately, when you're, a lot of y'all have been in the room with me, and I'm asking, when I first meet you, I'm asking you all kinds of questions. Well, tell me about your mom and dad. And this lady said, what do you want to know about my mom and dad for? They're dead. And I said, well, I'm trying to get to see how you link with ideas in your head and how you express yourself. Vascular dementia, language is almost always spared. In Alzheimer's disease, it's almost always involved as the frontal lobe starts to get involved. So yes, dementia would cause the aphasia. The aphasia does not cause the dementia.
So the timeline of how it typically progresses and known ways to slow it down. So the timeline is going to be, of course, depending on what was the cause of the aphasia. Was it a stroke? Is it more related to dementia? So the timeline is going to be very different between the two. And then what known ways to slow it down. Of course, I'm going to say speech therapy, of course, but also.
I'm going to say bourbon. Don't take me seriously.
But a lot of it is, like you said, the anxiety, the depression, the more withdrawn, the more social isolation you have, the less you practice your speech, it's going to get worse. So I encourage people, go do the activities you've always enjoyed doing. Go to Bridge Club, go to Bible study, go to book club, go to these things that are going to challenge the language, because the more you use it, the better it's going to be. So I don't know if you have anything to add to that.
We're trying to create new circuits around the ones that have been damaged. And the more that you pound on it, the better chance you have of doing that.
Okay, how best to respond to a person with aphasia?
To respond, what I like, of course, is total frankness about that if I have it, and I meet someone, you say, I've been having a little trouble lately saying some things, just give me a little bit of time. Or I might stutter a little bit. just give me a little time. That person is on your side, okay? If they make the observation and you're struggling and you don't want anybody to know it, they're gonna say, what the hell's going on here, okay? I have a little granddaughter and she's got special needs, and she was telling me, she says, Grampy, sometimes people, they'll prejudge me, or and I'll say, all you do is say, I learn in a little bit different way, but don't ever think that I can't get this. And I want that same spirit inside. Be honest about it. I've had a little stroke and I've been struggling with my words, but I kind of know what I want to say. If you'll be patient, if you say that, you got them. Okay, they're going to do everything they can to help you.
We even sometimes will have little cards printed that you could hand out to say, I've got aphasia, please be patient, please give me a little extra time. Just so that if you don't feel comfortable saying it, you can at least hand it to whomever you're talking to, and then they're at least aware that you want to let them know, so that, like you said, they're not dismissing you and thinking that you've got something going on. You actually have a language impairment. Sorry. So the next question, my husband has primary progressive aphasia. I'm not sure if that is expressive or receptive. So it's a different diagnosis than expressive. It's going to have a different prognosis. It's going to change a little bit more than somebody with expressive aphasia related to a stroke. It's a different neurological condition.
One of the things that happens it's a spectrum, but there's a thing called semantic aphasia. And semantic aphasia is that you actually lose the meaning of the word. And that you would say to your wife or something. This happens more with frontal temporal and frontal lobe, but pass the salt, and they'll have no idea what the salt is. Okay, That is extremely devastating. There are people that get primary progressive aphasia that they can't speak, but they are neurologically and cognitively totally normal, but they've lost the ability to speak. What's amazing is that there are certain strokes or syndromes where someone can dictate to a person that's had the stroke, and they can write down what you're saying, but they can't read their own writing. This is all very complicated, okay? But I mean, isn't that amazing that someone would say, I want you to write this down, and you write it down, and then you look at it and you can't read it.
So the next question, does receptive aphasia fluctuate in severity? What does it mean if a person can sing better on one day versus another? So the receptive aphasia is the ability to process the language like we were talking about. So it does fluctuate in severity. Sometimes I'll have people that can follow one-step directions and understand what I'm saying, but if I give them 2 or 3, they have a harder time. But sometimes the one step is different. So it definitely can fluctuate the same as expressive aphasia.
Fluctuations day to day in dementia and in speech issues have 4 etiologies. The first is hydration. That brains that have had strokes or have even mild cognitive impairment are very sensitive to hydration. Okay, so hydration. The second thing is bourbon doesn't count, by the way. Second thing is blood sugar. If your blood sugar gets up, okay, then you're going to pee a lot. You're going to get dehydrated. The third thing is medication errors. People have either forgotten their medications or they've doubled up on their medications. And the fourth thing is sleep issues. That some nights you don't sleep. That next day you are not going to be as sharp. So those 4 things are critical to staying as good as you can get.
What is the best training we can offer our employees who work with caregivers to clients that are living with expressive or receptive aphasia so that they are most effective while working with our clients? We want to shift to be a positive experience for both the caregivers and clients.
What I suggest on that, whoever that is, I want you to write me a huge check for my nonprofit, and then I'll help you.
What are the early symptoms of the disease? So with that, again, it depends on the etiology. So is it related to a stroke? That's going to be right away. The symptoms happen. I mean, most of the time, that's when you hear, is somebody having a stroke? It's the speech and language is affected. So again, the early symptoms of cognitive impairment are going to be different. And a lot of times, if it is younger onset, we will see the changes in the language more than physical at the beginning of the younger onset dementia. The language is definitely more effective. Physically, the body is holding on stronger, but the language definitely more impaired. I know what expressive aphasia is, but not receptive. We've kind of gone over that. So the receptive is understanding the language. Are there any medications or food groups to help with the conditions?
You're asking the wrong guy, because I think cheeseburgers are a food group. I think hydration and water is probably the most important thing, but no, there are no, actually, that's not true. The medications that we use for memory and we use for speech are related to acetylcholine in the frontal lobe. In about 50% of our patients, we'll see some improvement in patients. We had one clinical trial that we were involved in where the drug was really good for impaired neurons and getting sugar into the neuron. And all of a sudden, those patients, it's not been released, but they started to do much better verbally. And so we'll see about this, but no, currently there's nothing available.
Okay, how can aphasia be differentiated from catatonia or even possible selective mutism in adults when there is no evidence of stroke, tumor, or head trauma?
Well, in those entities, I mean, those are, I'm not so sure. Mutism is the inability to speak. Okay, that's not what expressive aphasia is. Okay, and catatonia is a completely different. So those are completely different entities, just completely different.
Is not being able to remember a word or a name, but knowing you know the word or name considered aphasia, and thus an early sign of possible dementia?
All right, I'll take this one. Language is a spectrum, okay? And it can be something as simple as, you've heard me talk about this, everyone here. Names don't matter to me. I don't care if you don't remember someone's name, all right? Think about this. When you're trying to remember someone's name, okay? And you close your eyes and there's their face and you remember everything about them. I remember he had the prettiest sister and, you're coming up with everything. But the name is an abstraction. It's a moniker that doesn't fit. It's just, and so what happens is that about 20 minutes later, you'll say his name and then you'll say his sister's name and then boom, it'll come. So I don't care about names, all right? The second entity is called anomia, where you're trying to come up, usually with a noun, that just leaves you, okay? It's part of aging, not a big deal. And so I don't worry about that. Then you get into expressive and receptive aphasia. Those are entities that can be associated with stroke, vascular disease, or dementia. Also, one of the things that we see are paraphasic eras. The eras are that you will, and you know this, if anyone has had expressive aphasia, you will get a word that sounds like the word that you want and you'll say it, or something that has a similar meaning. Like we had the other day, a wallet for suitcase. I thought that was pretty good. That's pretty good. And then one of the signs of intelligence, I think, is what's called circumlocution. And that is when you are thinking about something and that the word doesn't come to you, but you go around it and say it. And one of the ones that I like is that you're thinking of the grocery store and you'll go to your wife, where they sell food. Okay. I like that because you're sort of using your brain and then everybody's in on it.
And that's actually one of the things that we work on in therapy is I'll hold up a card and have the person describe it to me. What is on the card? They're having to tell me everything about what's on there. And it's to practice getting in the habit of, maybe it was a pineapple, whatever the picture was, and I'm having to guess it, knowing what it is. So we use that a lot in therapy, is trying to retrain the brain to go about it that way. If you cannot come up with the word, what can we do to talk around the word? So, are there any medications or natural food supplements that aid in the improvement of aphasia?
No.
So, are there any ones to stay away from?
Well, whiskey, whiskey is one, yeah, alcohol, probably having said this, having gone to the University of Virginia in the 60s, I'll have to get my diploma up after saying this, but alcohol really doesn't help anything, to be honest with you. I mean, it makes you feel a little bit better for a short amount of time, but does not help your cognition, doesn't help your relationship with your wife, doesn't help your expressive aphasia. So as we age, our ability to metabolize alcohol goes down. Okay, so silver oak does not count on this. So when we're metabolizing alcohol, there's an enzyme called alcoholic dehydrogenase, and it metabolizes it so it doesn't build up to high levels. And you see this all the time. Is an elderly guy will be stopped, and his blood sugar, his alcohol level will be really high. Well, he doesn't make alcoholic dehydrogenase; he doesn't have it anymore. Asians do not make a lot of alcoholic dehydrogenase, and they get a lot of side effects from drinking alcohol. So alcohol will make your speech therapy. Now, to have a small drink or whatever is not a big deal, but I like to have my patients have 3 full days every week of not drinking alcohol. One of the things about alcohol that is the most destructive, and it's probably not well known, is that it disrupts sleep. There are these 3 very deep plateaus of sleep, and during those times, there are these microglia that come and clean out your brain and protect it. And if you don't get down into those deep levels of sleep, it doesn't happen. So that's one of the reasons why large amounts of alcohol over a long period of time will affect your brain.
And the last one, like a quick list of what to watch for to see if a loved one has aphasia. How would you behave if they have it? So, like you said, kind of when you look at the spectrum, are you having a hard time with names? Okay, that's not as important. But if you start to see more common errors in speech, not being able to make your needs known, not being able to have that conversation that you were having before, then it is time to come and talk to Dr. Edwards.
It's not subtle, okay? And you don't have to go look for it. If it's there, it's going to find you. And if it's not, you don't need to go looking for it, because all it's going to do is make you nervous. I want to end on one thing.
There's a couple of questions in the chat.
All right.
So if you want to end. There's 2 questions here. Can you share some of the speech therapy tools that can be useful for PPA patients and caregivers to retain verbal abilities?
So a lot of that would need to be more specific to each person. So it would need an evaluation to kind of see what the strengths are with that person, what the deficits are, and kind of how to work with the caregiver. So it's not kind of a broad, hey, let's do this. It's more what not to do type of thing, and then kind of do a full-on evaluation.
And the last question in the chat is having the affected person read aloud an article to you a valid therapy to talk and laugh together about the text?
If I always think it's helpful, any kind of language we have come out, if the person is not frustrated, if the person is frustrated by doing the task and feeling that it's too challenging, that they're not enjoying it, then of course, no. I mean, we don't want to cause any extra frustration, but yes, anytime you can get fluent speech coming out, I encourage it.
One of the things that I like is I like to have I like to take advantage of everything that my patients can do, and they can understand in real time. And I like for couples to, if they're having, I want to have intimate moments during the day that break up the monotony and break up the challenges. So I like the patients, the caregivers, to read to the patient short stories or book that you've really liked when you were younger. But just hearing the sounds and making the images in real time is important for the brain, especially in fiction, because with fiction, you have to create the image that you are reading about. If you are reading about skiing down the Alps in a functional MRI, that part of your brain lights up. It just explodes. And so that's why romance novels are so big sellers. They sell more than anything, okay? Because when you're reading about falling in love, the part of your brain about falling in love is all aglow, okay? One of the, I have this physician, she takes care of her husband, and she's amazing. And and you've heard me say this, I'll ask, oftentimes I'll say, tell me what's going on at your house when you're both at your best, when things are calm and everybody's okay. And she goes, that's easy. It's when we're watching basketball and drinking beer. And I said, and she said, my husband's to the point where he loves the Carolina Tar Heels. And I have videotaped about 5 games where the Tar Heels win. Okay. And I'll sit him in front of the television, and he just has a great time. He's watching the Tar Heels win. And then she says, the beer is for me. So don't let marvelous relationships be ruined or marred by one issue. Find a way around it. What works at our house? What is it that we can work around? It might be that we take a walk, frustration, we work with that, but don't let this one thing ruin what, and this is only one part of it. And remember, talking is not one of the 5 senses. All right.
Quick final question here. What do you think about watching TV news for aphasia patients? Is that good or bad?
Well, you've heard my talk on this. I'm not too keen. I like people, I don't care where you get your news. I just don't want you to be on it all the time. I don't care whether it's left or right, it is poison. And they are trying to get you emotionally involved and pissed off at people who don't agree with you. And it's poison for your brain. We have to have positive thoughts. We have to reach out to other people. And so I'm not even going to answer that. Tell them that, TV. Don't get me started.
All right.
I have a question. Let me see if I can phrase this correctly. Is there always hope or room for improvement at any stage of dementia? I'm concerned about a patient being able to tell you that they're in pain and what hurts.
They may not be able to tell you, but you just have to. There are certain ways that we pick that up by being very aware of their physiognomy, their body habitus, and everything. So
I get that, but if you see all that and you think they're in pain, but they can't tell you.
So it's more anticipating. Yeah. So we have to anticipate.
and so then you would give maybe give Tylenol and see if that, goes away.
Change positions in the chairs. It could just be positioning. It could be, a lot of times as the disease progresses, you'll see that the pain receptors are not what they used to be. So it could be that the grimace is not pain. It could be maybe there's a bright light. So it's kind of like ruling out different things before you figure out what to express.
And oftentimes as we progress, especially in dementia, you will get more Parkinsonian features. So then you develop what's called a masked face, which is you don't smile, you don't have that radiance in your smile and in your face. And so you get this very stern look. And people think, is he in pain? Well, he's not in pain. That's just what the Parkinson's does.
But is there always a purpose for speech dementia at any stage of dementia?
No. There would be times when it would not be worthwhile.
All right. Thank you so much for all of this information. I don't remember a Take Charge Live where we hit every single question. So great job. Thank you for joining us. Thank you so much, Jessica. Thank you to Dr. Edwards. Thank you to everyone on Zoom.
For coming.
Thank you to everyone in person. Please have some cookies and some tea. And watch your email. If you registered for this session, you're on our mailing list now. So watch your email for an announcement about the next Take Charge Live, which will be after the holidays. Until then, happy holidays.